Welcome to the fifth annual National Injury Prevention Day annual webinar. Thank you all for being here today. My name is Dr. Wendy Pomerantz. I am a pediatric emergency medicine physician and one of the founding partners of National Injury Prevention Day, along with Lanita Johnson. As many of you know, Lanita passed away this past year. This is one of her legacies that will live on forever. We started National Injury Prevention Day 5 years ago to raise awareness that injuries are the #1 killer of people in the United States from 1 to 44 years of age. The actual day that most activities will take place is November 18th. During that and the surrounding days, our NIPD partners will wear green, shine a green light, plan and implement injury prevention activities, join the conversation on the Twitter X chat, get city and state proclamations, and much more. National Injury Prevention Day has grown over the past 5 years and now includes more partners and more insight into this national problem. Each organization brings to the table expertise and membership that helps to execute the day's activities. Injury Free serves as the umbrella sponsoring organization overseeing and promoting the day's events, capturing them on the NIPD webpage of the Injury Free website and tracking their completion. This year, the format of the webinar will be a fireside chat. Feel free to put questions in the chat and we will answer them later. So now I am happy to introduce Dr. Allison Arwady, who will start things off for us today. Dr. Arwady is the director of the National Center for Injury Prevention and Control, where she leads CDC's initiative, research and science-based programs to prevent injuries and violence and to reduce their consequences. She has a bachelor's degree from Harvard University and a master's degree in public health from Columbia University. She completed medical school and clinical training at Yale University, and she is board certified in internal medicine and pediatrics. Dr. Arwady previously served as the commissioner of the Chicago Department of Health, leading the health department, one of the nation's third largest city, including through the COVID-19 pandemic. Prior to that, she spent 4 years as Chicago's chief medical officer, overseeing the department's behavioral health and disease control work. Under her leadership, Chicago's behavioral health team established dozens of innovative programs and partnerships in substance use and violence prevention, as well as mental health promotion and linkage to care. Dr. Arwady has received local and national recognition for her strong leadership and communication skills. Please join me in welcoming Dr. Arwady.
Thanks so much, Dr. Pomerantz. It's really such a pleasure to be here. Thank you to all of us who have joined. I think we're going to have a really good and interesting conversation today. I do just want to start by congratulating everybody who has been working on this movement. This does this year mark the 5th year of Injury Prevention Day. And for those of you who have been following along, each year this has been growing. I would encourage you, if you look online, you can see last year we had 95 cities in 39 states that were lit up green. You could see a picture of Niagara Falls, for example, lit up green for Injury Prevention Day, and we'd love to break that record this year. Just as important as lighting those buildings up green is sharing the information and the news and the data about injury and violence prevention. Too many people in this country do not know that injury and violence are the leading cause of death in the first half of life, and that so much of this is preventable. And the work that we do together around the country is improving these statistics every day, is really making a difference, and we want to continue to lift that awareness together. So just to, go ahead and kick to the next slide. As you know, injury is a leading cause of death. Depending which age group you look at, these different topics are in the leading causes. So overdose, for example, is the leading cause of death for people between the ages of 18 and 44. Drowning between the ages of 1 and 4. Suicide is second leading cause between 10 and 34, and it goes on. These topics that we focus on and more, we don't choose them just because they're topics we're interested in. We choose them because they are what are killing Americans. They are causing a lot of disability. They are causing a lot of expense, and importantly, they are preventable. So if you move to the next slide. Just again, to the point, we consider all of these topics urgent, related, and preventable. And for example, at CDC, when we're talking about our injury and violence work, we often share the shared risk and protective factors for example, suicide, overdose, and adverse childhood experiences, and really make sure that when we are talking about any of these issues, we think about the links and we think about how to make sure interventions are not theoretical, that they are based in evidence and that they are being applied and evaluated to continue to make a difference. Next slide. And then just finally, I think we're going to be talking today, I know, some about health equity. This is the U.S. Department of Health and Human Services definition for health equity, when everyone has the opportunity to be as healthy as possible. I think at CDC and at the Injury Center, we often talk specifically about making sure that we are using data to put our focus where the impact will be greatest. And that means in our programs, that means in our measurement and in our data, that means in our policy, and then importantly, thinking about the infrastructure that lies underneath this to make sure that we're focused where we most need to be focused on these topics. Last slide, or I think that might be the last slide. Yep. And so just wanted to set that up very quickly. And now we're going to go ahead. We've got three really excellent panelists who are doing this work every day. I'll be just facilitating communication, but feel free to put questions in the chat. I'll be watching for those. So I'm going to let them go ahead and introduce themselves. So let's start with Dr. Lois Lee.
Hi, I'm Lois Lee. I'm a pediatric emergency medicine physician here at Boston Children's Hospital and an associate professor of pediatrics and emergency medicine at Harvard Medical School. I also have the honor of being the past president of the Injury Free Coalition for Kids and currently am the chair of the Council on Injury, Violence, and Poison Prevention at the AAP, one of the partners for National Injury Prevention Day. So thank you for having me.
All right. And Dr. David Schwebel.
Yes, hi. It's great to celebrate National Injury Prevention Day with all of you. I wear three hats, two of which are relevant here. So first, I direct the UAB Youth Safety Lab here at the University of Alabama at Birmingham. We conduct federally funded research largely on child, adolescent, and young adult injury prevention. Second, I serve at UAB as the Associate Vice President for Research Facilities and Infrastructure. That's more of a university administrative job. And third, some of you know me as the author of the book, Raising Kids Who Choose Safety, which is designed to help parents keep their children safe and raise children who make safe choices and prevent injuries.
Great. And then finally, Dr. Sadiqa Kendi.
Hi, everyone. I'll be on video in just a minute. I'm in transit, but really excited to be here with you. So my name is Sadiqa Kendi. I'm a pediatric emergency medicine physician at Children's National Hospital, where I serve as Associate Division Chief of Academic Affairs and Research, and also Chief Medical Officer of Safe Kids Worldwide. And as I said, excited to be here.
All right, wonderful. And I do just want to give a special shout out to Columbia University, who is pulling together all of these folks from around the country. I think it's just a beautiful example to kick off this week, celebrating leading up to Injury Prevention Day. So I think to kick us off, Sadiqa, since you're getting online there, let's start maybe with a question for you, David, and then we can move on from there. So I know this is something you've thought a lot about and done a lot about, but in the field of injury prevention, what do you see as some of the best ways to move data and science into action? How do we deliver interventions that really make changes to decrease injury?
Yeah, thanks. So important for us to recognize that we need interventions that change people's behavior, that move from ideas to action. So how do we do that? First, when we deliver an intervention, we want to make sure that it has underlying theory, that there's reason to cause behavior change. And we want to know that it's effective, that there's some science behind the fact that it will make a difference. Second, we want to make sure that the intervention is delivered in a way that it was intended to be delivered. There may be reasons to modify and make changes, but making too many changes depending on the intervention could cause it to not work. So we want to deliver the intervention the way that the research and the science suggests it should be done. And third, and this is so important, we need to congratulate ourselves. There's an awful lot of research published in those journals, and they're useless unless they're implemented. So we need to congratulate ourselves, remember the importance of what we're doing, of taking those well scientifically developed ideas, putting them into action, and making people's lives safer and healthier.
Great. Lois or Sadiqa, would either of you like to add anything to that, just around kind of turning some of this science into action?
I think, as David said, it's all well and good if we publish it, but if we don't implement it, it goes nowhere. And this is where really engaging the community is really the most, important thing, whether or not it's through working with community organizations. For example, we did this program around safe sleep between the AAP and the Injury Free Coalition for Kids. And we used community partnerships with organizations to deliver safe sleep materials, including safe sleep sort of cribette to families even before they had the baby. So we started the education and then provided them with the materials because we know that families have the same goals that we do. Everybody wants their children to grow up safe and healthy. And so I think sharing that message and then providing people with the tools, working with the community to develop the messages in a way that is culturally relevant to them and appropriate helps then turn that implementation into real action.
Great. And maybe let me take that just one step further for you, Lois. So this piece, I couldn't agree more. The goals of injury and violence prevention are shared. They are shared by every family. They are shared by every policymaker. But I'm interested specifically where we think about those policymakers, which is often where we need to be doing additional education and where, frankly, our voices are not always as loud or as organized, perhaps, as they could be. So I'm curious, I know that you wear that policy hat in your role a little bit too. So if an organization wanted to influence policy, concerning safety or injury prevention, where do you recommend they start? Do you think this is something, local, state, federal? Do you think this is better organizing around a particular topic? Just interested in some of your top line thinking on that. And either of the others can feel free to chime in as well.
Well, it certainly helps to have a specific topic. And so we'll choose maybe child passenger safety because although all the states do have very good laws around child passenger safety, there's still improvements that can be made for best practices. For example, in my state of Massachusetts, we are starting the process to introduce a bill to keep children sitting rear facing until at least age 2. And to do that, I'm working with the Office of Government Relations in my hospital. So most hospitals do have an Office of Government Relations, and those members already have working relationships generally with your state legislators and depending on the issue also at the federal level. So if you are at a hospital, and many of us are today, and you don't have to be an MD, actually this is a role anybody in the hospital can reach out to their Office of Government Relations, start a dialogue on what are the important child safety topics for your state. And again, child passenger safety, there's always new things that we can think about. And that's generally a place people understand. It's not politically fraught, and it's important because it still is a leading cause of death and disability for children and adults in the United States.
Great. Sadiqa or David, anything you want to add to that?
The only thing I would add is just the importance of storytelling as well. I think that, we all think about the data, and I think the data is incredibly important. But I think also just having stories to really humanize what's happening and humanize the impact for policymakers can be really important. And sometimes that storytelling, like you think the data, like saying like this is a problem and this is the evidence should be enough. And but sometimes like being able to put that human face on it, share a family story can actually be really helpful.
Yeah, absolutely.
Yeah, I agree. I'll just reiterate, you don't have to do this alone. There are government relations offices, there are people who can help. Find the help and get it done. And I'll reiterate another point. You can take action and have impact locally. You can have impact at the state level. You can have impact at the federal level. And you don't need to do it all. We can have impact at all of those levels. Find the easiest opportunity and pursue it.
Yeah, thanks. I think wherever there are, government relations offices, you want to make sure, this is just my opinion, but really they are aware and thinking about these topics, where we can attach these topics onto conversations that are happening. When I'm talking to policymakers, which mostly I do in DC, I'm mostly doing that at the national level, just given the role that I serve. We regularly hear that they have heard from universities, they have heard from hospital partners, they, when I'm coming in and sort of saying, what do you know about injury? What do you know about violence? How do you know about the work that's happening, in your state or wherever you are representing? I find that it is often a lot of those partners that perhaps have the strongest existing relationships. And that goes all the way up at the different levels. And so I think, just as a very practical thing, I like that a couple of you mentioned that, making sure that these topics are included in the big conversations that are happening, and because they should be. Again, leading cause of death, first half of life, and preventable. Thanks for that. So Sadiqa, maybe let's turn to you for a second. Right up front, I gave a little bit of the language that we use when we're talking about health equity, whether or not we always use that word specifically. And I'd love to kind of turn to you a little bit, because I know this is a space that you've done a lot of work and thinking in with your team. So how do you define equity, particularly in terms of injury and violence prevention? And any suggestions for folks on the call here who also want to make sure that we're keeping that as a focus?
I think I define it the same way that you did, is, that highest form of health for
Mm-hmm.
everyone, and for everyone to have the privilege of being healthy. And I think when I think of injury as one of the ways that you can reduce or take away someone's health. And so I would extend the definition to say having your highest form of health and being free from serious injuries. And I think that if we prioritize equity in all of our injury prevention work, then it benefits not just those who are impacted most, but it benefits everyone. And that's why I think it's so important to be thinking about equity, to be considering equity in every endeavor, whether it's a research project, programming, advocacy. That equity should be one of the foremost kind of concepts that you're considering as you're thinking about the injury prevention work that you're planning.
David or Lois, anything you want to add to that?
I think just to build on that, really thinking about equity as far as access to equipment that help keep children safe, access to environments that are safer for children, and then making sure that education is also equally accessible to all families, so that they know really what are the best ways to keep their children safe. Because again, doesn't matter who you are, where you live, we all have those same goals.
Yeah, absolutely. So maybe I'll stick with you for just a second, unless David, did you want to chime in anything else on that last one? Okay. So thinking a little bit again about lifting this voice, right? Like lifting this voice together. I noticed in that example you just gave, you had 3 E's in there. I'm guessing that wasn't by accident, right? Equipment, environment, education. Like some of these messages that resonate, that others can lift up. Again, where I'm thinking about, for example, for folks on this call here, let's say they either haven't engaged with their government affairs office, or maybe they're with an organization that doesn't have a government affairs office. What does that actually look like? What does it look like to sort of think about reaching out to legislators or policymakers at different levels? How do you get a chance to talk to them? How do you get a chance to influence policy? Guidance for people who may be thinking about doing this in the context of National Injury Prevention Day or ever?
Well, I can start with that. So I would definitely, pick one issue. There are many different issues that you can choose. So I think choose one and choose something important locally. So for example, let's just start with the state example. And again, because it's on top of mind for me, are rear facing until 2 years of age. And as a constituent, it is actually your privilege as well as your right to reach out to your local, state senator and state representative. And it's really building these relationships over time. You're not going to necessarily get a bill passed, the very first time, but you start learning, who are the staff people, and you don't necessarily meet with the legislator, and that's okay because they have many things they're dealing with. And so knowing their staff is very important, and meet with them serially over time, maybe about one issue, maybe about multiple issues. Same for your federal, Congress people and your senators, your constituent. And it is absolutely your right to reach out to them, build these relationships over time if that's appropriate at a federal level. Like anything, the first time you do it, it's really scary, but then you realize these are people too, and their job actually is to listen to you because you're a constituent.
Yeah, and these are topics that touch every family. That's all. I always remind people about that, when you're out talking to people, even if you're maybe newer to doing some of that education, it is unusual for it to not be a topic that directly or indirectly, has touched those folks who are working in policy offices, just like it's unusual to talk to anybody in this country, unfortunately, that these topics have not affected. Sadiqa or David, anything else you would add on that piece?
Yeah, I'll build from Lois's point of it's really scary the first time because that's
Yeah.
true. And I'm a psychologist, so I can't avoid addressing that. You know, start easy. You can write a letter, you can write an email, and that's an easy way to begin. And then you might work yourself up to, oh my gosh, they responded to my letter and they were supportive. I'm going to make a phone call. And then work yourself up to in-person visits. And yes, you'll be a little nervous the first time, but you'll get through it and you'll get really good at it. And it builds on time like anything in life. So overcome what might be a little bit of trepidation and push forward because it's worth it and you can have impact. And we have stories about how we've reduced injuries through policymaking and the work of all of us to get policies changed.
Yeah, I'll add on to what Dr. Schwabel just said, which is these emails and phone calls, they are noticed. So don't feel like they just go into the ether and nobody's paying attention. I worked in the senator's office for a brief time, and every week they actually reported out. We got 15 emails about Medicare. We got 10 phone calls about Medicaid. So, your voice matters and they do catalog this. And I'm sure every office does it differently, but don't feel like it just goes into somebody's junk email box. There is somebody assigned to read it and pay attention and make sure that whatever legislator you have reached out to, either by email, phone, or in person, knows that this is an issue for their constituents.
And I was just going to add that for people who are clinicians, there are opportunities to kind of start in a group setting. So through the American Academy of Pediatrics, they have an advocacy program that really kind of teaches you how to do it, has you actually go up on the Hill with people like Dr. Lee who have done this before. And so there are opportunities that you can search out to kind of get your feet wet and get that experience if you don't want to start with a letter or if you've done that and you want to kind of think about the next step.
And
Yeah,
every
great.
state has an AAP chapter. Some states have more than one AAP chapter, so that's a great way to start too.
Yeah, and I think, similarly, depending a little bit, of course, like it's important that you're talking with your institution, for people who are federally funded, you can't be in a lobbying group, but that doesn't mean that you can't and shouldn't be doing that education. You want to make sure that the folks who represent you at every level, the local level, the state level, the national level, they want to know you too. I think it's important that people recognize this. Like they want to have somebody who they trust, who is an expert or who is working in this field, who can get them data that they need, who can help really understand where some of the gaps are. And so I think building some of that relationship over time, I think sometimes people think of it as like, I'm lobbying, I'm this, I'm that. In many cases, again, depending again a little bit on your institution or on your funding, in many cases, those connections are about saying, this is an issue that's important to me, but let me also explain to you, if you're working in this field, you're bringing some important information. And importantly, like we've said a couple of times, but I'm just lifting it up because I agree, this connection to their communities can't overstate it enough. That's what people care about. They want to know the stories, they want to know the data, they want to know why this matters, and then like why are you coming to them, right? Like what could that role be? And you don't have to have like a big plan to change the world. It's about raising some of that awareness, I think. So appreciate that. So maybe back to Sadiqa again to kind of kick us off a little bit. There's been, I know a lot of times when I'm talking to groups, who are thinking about how to prioritize different areas, how to, even identify which group to focus on and looking at some of that data and injury. There's this intersectionality piece, right? Which I think is really critical, and not that it's not critical to every issue in health, but I think for injury and violence in particular, that aspect can kind of play an outsized role. I'm curious about your thoughts on that. Do you agree with that? If so, maybe for folks who aren't as familiar with that term, just what is that? How might it apply to injury prevention? How do you think we should or shouldn't be thinking about that in our work?
Yeah, I definitely think that it's a really important aspect of our work. I mean, the injury equity framework that I developed and published with Dr. Michelle Macy Intersectionality is one of the pieces of that because I think it's just that important. And for anyone who's not familiar, intersectionality refers to that interconnected kind of notion of identities that you can see in people or even in individuals. And so it might include their race and ethnicity, gender, sexual orientation, geographic location in which they live, and many other forms of identity. And even though we know that so many forms of identity are social concepts, they're not biological concepts, we know that when you look at all of those together within various forms of discrimination, you can actually end up with worse outcomes because of that kind of intersection between their identities and various forms of discrimination. And so, for example, we know in a study that I did with CDC colleagues, we saw that Black children were at higher risk of dying from motor vehicle crashes. But then when you look at Black children from the most rural areas, they're at a much higher risk of dying from motor vehicle crashes. Similar with white children from very rural areas, we're at a much higher risk, although Black children from rural areas were even higher. And so, really thinking about that intersectionality, I think is helpful when we think about how do we address these inequities in injury. We really do have to think about those various forms of identity and how we can create solutions that really address all of those ways in which inequities are increased.
Yeah, that was a really good overview. I think it's been very interesting as I myself have learned a little bit more about this and learn from you and others, just the ways in which you can actually miss some of that if you're not thinking how these might intersect. And I think particularly where we don't have unlimited resources and we're wanting to make sure that the focus is where the impact will be greatest. I've been particularly interested, so thank you for that. Lois, David, anything you'd like to add to that part of the conversation?
Go ahead, Lois.
I think as we are getting better and better data sources. I know the CDC did a big revamp of Whisker, so we're able to get more data and really leaning into that and making sure we're not just reporting aggregated numbers, but focusing on specific subpopulations, because then kind of going back to what Dr. Schwebel said before, right, where can we implement the interventions where they're needed most?
Yeah, I'm going to add one more piece. So I think the original question was incorporated. How do you prioritize? How do you decide where to put the focus? And that is really challenging to all of us because there's so much need in so many groups and so many types of injuries, and the resources are limited. So I think you've heard about impact, and I absolutely agree. One piece of the equation has to be impact. Where can I have the greatest impact? Where can I reduce the greatest number of injuries? Where can I prevent the greatest number of deaths? I'm going to add a second piece. How easy is it to do? There is so much that we could do. What is feasible? What does your budget allow? What does your labor force allow? What can you actually deliver and deliver well? Because delivering something half-heartedly is probably not worth the effort. So yes, number one, what impact can you have? And two, what can you actually get done with the resources you have and get done effectively to reduce injuries?
Yeah, I love that. Either of you, on this sort of prioritizing work, it's a huge and complicated topic.
The only thing I would add is just that I do think that there is a role for sometimes pushing the boundaries a little bit on doing something that maybe hasn't been done before or hasn't been considered, especially when we're thinking about addressing inequities which have been persistent over time and in some cases have widened despite the reduction of the prevalence of certain types of injuries. And so, I think that prioritizing things that are feasible is very important, as David said. And I think prioritizing you know, what the impact will be for those populations that we know need it most. But I would also say prioritizing trying something new, especially if we know that what we've done for so many years has not impacted inequities in the way that we'd like.
Yeah, I think for me, this makes me think of just an example from CDC where, as you know, lot of the American Indian, Native Alaskan tribal populations really have outsized issues on a lot of these topics. And it's been interesting, with my team at Injury, where certainly we're wanting to make sure, evidence-based interventions are being supported, et cetera. But there's also been this real conversation around what does it look like to have sort of tribal-led evaluation, like in a way that is maybe different than the traditional way. Like this thing of saying something that we are doing collectively is just not working yet, or not working enough. And sometimes that's a matter of often it's a matter of resources, it's a matter of all kinds of things. But this thing around actually sort of evaluating in a way that kind of speaks to a community and involves that, I think has been a newer space, at least for CDC, and a space I think that, we're continuing to grow in. And so for me, I think, David, thank you for bringing us onto this topic. It's also about where are we not moving the needle, where we've tried, right? Where we've made investments, where we think we've got evidence, we think we're putting things in place, and yet things aren't moving. Though that for me also is a place where I hope we kind of lean in and think a little bit differently. And in some cases, like we're trying to do in the tribal space, there's just a completely different approach that we could potentially be taking. So I appreciate on that. And maybe like just to take that kind of then one step further a little bit back to this implementation piece. So, how do you build an intervention to prevent injuries that works? How do you know that's working? How do you have that focus? Maybe David, we'll start with you and then invite the others to chime in. And I'll just remind for the audience, do go ahead and drop questions in the Q&A, and we'll be lifting those up too as we move into the last 15 or 20 minutes here.
Yeah, good. So, boy, how do you develop an intervention? It's not easy. Let me start there. I think first you need to define the problem. You need to recognize that anything we're addressing is multifaceted. So let's take road traffic injuries. Many of us know about that. Our friends in engineering design better roads. They also design safer vehicles. And we've had tremendous injury prevention through road engineering and vehicle engineering. Many of us, probably not everyone, but many of us on this call are more focused from the behavior, the public health perspective, the behavior change perspective. We can change drivers, we can change pedestrians, we can change passengers. We can create ways to change behavior to make people safe. And I think when you're defining your intervention, you need to look at what am I trying to change? So once you've got your problem defined, then you need to think about the theory behind how do I change that behavior? Okay, what sorts of mechanisms are going to change habits that might be long-standing? And that is hard to do, right? When we've got a habit we've engaged in for years, decades, it's hard to change it. So you need strong theory to get that behavior to change. And then you need to do the research before you go do an intervention. You need to do some research to show that, yes, it's going to create that behavior change. It works. And then, of course, we get to the last stage, and I'm probably skipping some steps, but the dissemination. We've got something that works. I've done it locally. How do I get it used across the country, across the world? Now, I've just said in 3 minutes what probably would take 40 years to move from start to finish. And we're at various phases of all of these interventions. I think deep down we need to remember that not one thing is going to prevent an injury. We need to be multifaceted. There's many factors that come together to cause an injury, and we can block any one of those factors to prevent an individual incident. And so you're going to have an impact with an intervention. You're not probably going to be fully successful. You're never probably going to prevent every single X injury. But if you can reduce from 100 to 90 to 80 to 70, you're having success. And we need to remember that, celebrate that success, and keep working to get more success.
Absolutely. Either of you want to chime in? Otherwise, we'll go ahead and turn to some of these community questions. And I've always got more questions.
So I think an important thing Dr. Swable said is that it's one intervention may be effective, but that's not going to, basically solve all our problems with injuries. So go back to a longstanding framework, the Haddon matrix. Really, there's lots of different phases in time and different, parts of the injury episode that can be addressed. So one specific intervention will just be part of kind of multiple things that would have to be done on a population-wide level. And the dissemination piece is really tricky. I always like to say, there are new parents born every day, right? And so new families that are still just learning about how to take care of newborns and all the different injury prevention things they have to know throughout the life course of the child and even as an adult. And so our work is definitely cut out for us. We will always all have jobs. I guess that's a good way to look at it.
And the one thing that I'll just add before we go to more questions is just that I think that when we think about inequities, it's very similar in that we really have to think about a multifaceted approach. I think for so long, we often just thought about behavior and education. And I think, especially when we're thinking about inequities, there have to be interventions outside of behavioral and or education interventions. And that's what we tried to capture in the framework. And that's what I've been thinking a lot about and talking a lot about, because I think in order to move the needle, we have to think about all of those different buckets that are in the Haddon matrix, and then all the other societal issues that impact inequitable outcomes in families.
Absolutely. So I'm going to summarize a few of the questions that have come in the chat already. Feel free to keep dropping them in. To go back a little bit to some of that work with government relations teams or with policymakers, first, there's just a comment. Someone is saying now could be a good time to introduce yourself to local policy makers or state legislators, House, Senate, et cetera, post-election. And in this case, it's a pediatrician. Just say, proud pediatrician voice, really lifting that up, but recognizing that this can be a real moment when there's been change to be in that conversation. But there's a good question here. Someone's asking, when communicating with your government relations team, how do you recommend that we prioritize these topics when there are so many competing pieces for legislative focus, particularly in the hospital care arena? I think it's a great question. Do you guys have suggestions on that?
Well, I can start, I think, looking at local data, and if you have community voices, because it's not just about what the hospital or your institution thinks are priorities. It's really important to know what the community feels like are priorities as well. And certainly working at a children's hospital, I feel like one of our jobs is to represent our community, because we do have voices, we do have those relationships, and we can be sort of that agent for change, but also joining with people from the community to also testify, to speak, to bring, their concerns is important. But I think start with some local data. That also includes getting the information from your community needs assessment if you are a nonprofit institution, and that can be one way. And then also you have to see, well, what actually is winnable? There's certain topics and certain sessions that you just know may not go very far. But then again, you never know. We managed to pass an ATV bill here in Massachusetts, probably the only state that will ever do that. But when we started, we had no idea how we would move forward, and we were able to get a wide range of partners, because it's not just one institution, it's a lot of different people and partners that you have to work with to bring things to fruition and real change. So use your local data, but then sometimes you just have to try and see where it goes.
Great. Thanks, Dr. Lee. Either of you want to chime in on that?
Yeah, I'll just piggyback. Think about what the legislature's priorities are. Certain legislatures champion agriculture. Maybe you push agriculture and rural farm safety with them. Certain legislatures champion education. Maybe you push child safety with them. Think about ways to find common ground with the policymaker.
Yeah, and I would also just add that, if depending how things are going, if you're in the hospital setting and you're having those conversations, I think another really important partner, if you're not already connected and you're interested in this space, would be your local or state health department, who are also very much thinking about this, can be supportive of data, want to have more of those connections, most likely, between sort of that public health side and that clinical side. So I think that can be another really sort of practical place to kind of lean in, learn a little bit more about this space. And it might, I know sometimes for providers, it's not the most obvious obvious connection, but I think on this topic, it can be a really productive one, no matter where you are in the country. So would also encourage that.
We've done a lot with the local councils and local legislators to be, like with our bike helmet laws. We don't have a state one, but we have a lot of local ones.
Yeah, exactly. And, I mean, you guys know in these spaces, a lot of the most innovative and new trying things, a lot of it has come from local levels, transportation and others. So, yeah, thank you for that.
I have one
Okay.
more thing. Actually,
please.
sometimes a patient story helps make it a priority. That's how the ATV law got passed. There was a child who died when he was visiting a friend's house and got on an ATV. And so sometimes that drives your priorities, are actual real patient stories.
Absolutely. Perfect. Okay, so there's another question here related to some of this prioritization work that Dr. Swaybo was bringing up. So, person saying, I think community could use a little bit of guidance on, how do we invest based on the level of funding that's available? What are evidence-based impactful programs that you could do that are sub $1,000, that are sub $5,000, that are, growing, particularly if you're sort of newer in the space, because you think about scale, et cetera. What can you do when you don't have a years-long $2 million federal grant that is supporting some of this work? So that's another really good, very practical question.
Yeah,
Maybe
that's a great question. Yeah, I mean, I would go back to my message, think about impact and think about feasibility. And, if you've got smaller budgets, the $1,000, the $5,000, I would look at existing interventions. And I would probably, there's lots of ways to take this, but I would think first of interventions that we know are going to reduce injuries through an environmental change, a more passive, for those of you who know the active behavior change versus a passive intervention. So gun locks, cabinet locks, stair gates, car seat interventions, things that are going to keep the person safer through a device often, or through installation of a device for a relatively low cost. We know they work. We know they're not in every household or in every vehicle, and we can get those disseminated fairly low cost to a lot of people. That gives you your impact for a budget that is more manageable in places where I know many people work.
Anybody else want to chime in on that?
I was going to say the same thing. Like we know that we have home safety equipment. We equip families' homes. We go in, it's relatively inexpensive, less than $100. And we know that they prevent the injuries they were meant to prevent. Car seats, booster seats. There's a lot you can do with just a little bit of money.
And I'll add, if you do those programs, often you can augment that money with maybe foundation funds or philanthropic funds, that your institution can do. And so you can add up all these things. We've gotten state grants for getting car seats for a long time. And so we're able to provide car seats for free or at cost. And we have a process here for screening every child under the age of 8 who comes in through the emergency department or who's hospitalized. And we can provide education and a car seat if needed.
Great. A good question here about partnership. Have you had any success with finding unique partners who may not have traditionally been in the injury prevention space to creatively develop new interventions and programs? Or I would add to that to help, raise awareness of these issues.
So I can start. I can start with just a partner that I've worked with, which is the National Center for Fatality Review and Prevention. When I first started doing injury prevention work, I had heard of Child Death Review, but I didn't even know the National Center existed. And then, through some of my work, ended up meeting the director of the National Center, Dr. Abby Collier, and met others with the National Center. And now I did a year of work with them and developed a kind of new process for evaluating inequities in injury that we call Mass Peer. And we're working on a second year of that work. And so that was a partner who I had not thought of as traditionally being an injury prevention partner. But if we think about Child Death Review and the number one killer of children, it makes sense that, they could be a good partner. And one of the things we found in our work in that first year was just that, sometimes there are partners who might be non-traditional who could be really helpful for certain things. So the people who do building codes could be really helpful if you're thinking about whether or not you can find a way to have, pool fences work a certain way, or requirements around pool fences for certain areas. So there are non-traditional partners that we've started to think about through that process, who are not at all focused on injury prevention, but do work that, if you can work with them, could actually impact the work that you're doing, and help with interventions that would prevent injury.
Uh,
I can give an example from our ATV law. We one of our partners was the Sierra Club because they were looking at children on ATVs in public lands as an environmental thing. So sometimes thinking outside of injury and seeing what are the other impacts, who are other partners who'd be interested in this, was really important in thinking kind of outside the box.
And I'll give two examples quickly. One is connection to an attorney who is representing, unfortunately, a very sad case where a child passed away, and we partnered. I did some research. There was litigation, and it created product change and made the country safer through the product change. Second example is technology. Actually, a project Sadiqa and I worked on together, that technology developed by a local small business. They were using it in industry, and for a very different area, we applied it to car seat use and help parents install car seats through remote instruction. So that's two examples: working with an attorney, working with a local small business, a technology software business. There's people out there, and the more people you meet, the more you talk about what we do, the more you find common ground to solve problems together.
Great. We're in our last 5 minutes here of the panel discussion, so I'm going to try to get through maybe one or two more if we can. Maybe just to build on that partnership conversation, a comment here from somebody who works with the U.S. Consumer Product Safety Commission's National Electronic Injury Surveillance System, or folks probably know it as NICE, says we're always looking for new and innovative ways to promote our data, get hospital networks interested in participating. And the questioner is asking, do you have any advice on where to find the best injury prevention champions within a hospital network? So this is someone external wondering how best to sort of connect within a hospital. So thoughts on that?
Well, one way is to come to the annual Injury-Free Coalition for Kids conference, where you'll meet, attendees from over 40 hospitals in the United States, primarily children's hospitals with trauma centers. So that's one way. But many children's hospitals and other hospitals, anyway, if you have a trauma center, you have to have an injury prevention program. That's a requirement from the American College of Surgeons if you're going to be a trauma program. So I think just starting with looking at who's in the injury prevention program manager at the hospital is probably a good way. And there's usually non-clinical staff as well as clinical staff who are affiliated with those programs.
And I was also going to mention trauma programs at the different hospitals. I think that's a good start. In addition to Injury Free Coalition for Kids, there's Safe Kids coalitions in a lot of different places. So looking for a local Safe Kids coalition. And then the Safe Kids Conference is coming up in October 2025, called PrevCon. And that's another space to connect with many of the coalitions who are partnered with various hospitals. Not all of them, but some of them are partnered with hospitals. So I think all of those are great ways to get in with hospital-based injury programs.
All right, great. And we are just about at time. I do want to note, someone put a question in here about, do any of you have an HVIP, a hospital violence intervention program that Medicaid is reimbursing for case manager assessments? And this is sort of a specific question, but I think it is getting at sort of this question of funding and supporting this kind of work in a reimbursable kind of way. And I don't know if any of you would like to comment either on that specific question or a little bit more broadly, some of the work in that space. And certainly that is work that CDC is very interested in, continues to talk with CMS, Center for Medicare and Medicaid, thinking about what that looks like. Different states are in different places. But do any of you want to comment at all on that sort of reimbursement piece for some of this work?
I know in North Carolina, they're using their Medicaid waiver to provide funding for their hospital-based violence intervention programs, and also I think for some of the community partners as well. I don't have the specifics on that, but I could reach out if this person, whoever asked the question, they want to reach out to me. I can probably find a contact through the AAP who might be able to provide some more information related to that.
All right, great. And I think we are just about at time. I will just know, we didn't get to someone was asking a question about tribal partners. I mentioned, a little bit of what CDC is doing, would refer you to the website, at least to get you started there in terms of understanding some of the funding and work that is happening. I think for time we can't get into it, and I'm sure there's more, but thank you for raising that. A number of folks were putting in just comments wanting to really lift up the safe system approach at the core of the Department of Transportation, of course, roadway safety strategy, which is about zero fatalities. Some other links and suggestions here for people in the chat to kind of take a look at. And then someone was asking, how do you feel about the upcoming administration change? How might that impact our ability to make strides in injury prevention? I will just say these are very bipartisan topics. These really are truly topics that affect every corner of this country, that unfortunately, remain leading causes of death. That's where we started and where we're ending here, and that are preventable. And I will just note, for example, on overdoses, President Trump was who declared this to be a public health emergency, started a lot of the major funding around this, has said that this is something that we should work on, ending in this generation. And I think, these are topics certainly that bear continued focus. And it's just really important that at any time that there is a change in any kind of administration, that we are speaking with a voice around those facts and the ability that this is something that we can make progress on. So I think National Injury Prevention Day is a really good opportunity to sort of be doing that, raising that awareness, again, as one voice, not in a political way, but in a way that is about these are topics that we all care about, and that our leaders and families across the country care about. So I think maybe with that, thank you for, again, to Dr. Pomerantz, to Dr. Kendi, Dr. Lee, Dr. Schwebel. Really appreciate all of your insight. Excellent conversation, so much to do, but I hope it was useful for folks on the line here. And with that, I believe I am handing it over to Delena for the next portion. Thanks.
Hi, thank you. Thank you, Dr. Arwadi and all the panelists today for this very insightful discussion. I can't wait for the recording. If you were taking notes like I was very quickly, you might want to just join in on that recording. But right now I'm going to set it off to Richard Hamburg, who this last piece of conversation that we had is very important reason why he was invited here, because he is the executive director for the Safe States Alliance, and he has so many years of experience working in different settings, government, private agencies such as the American Heart Association. So he has and he's a New Yorker, just like us up here. And so we would value some of your insight as to that last question with regards to the new administration, maybe, and what we can be doing at the moment from your perspective and from an advocacy perspective, how we should handle it going forward.
Yeah, thanks, Delaney, and glad to join all of you today. That was a great conversation, and so much of it was around awareness and the importance of raising awareness of the burden of these issues, the return on investment when there are sound investments, and also we need to acknowledge potential threats to to all these programs, not just at the Centers for Disease Control and Prevention. So what I wanted to briefly call your attention to is it's always nice to express general support for a principle. In this case, raising awareness about injury and violence prevention before you're actually asking for something. And so one of the things that we did, the steering group, National Injury Prevention Day, is we wanted some sort of document to capture just general support for the work that we're doing, and we started a couple of years ago, and I'm pleased to report that we have more than doubled the number of groups who signed on to this letter of support. It's now over well over 110 organizations, and it's a good mix of partners who are likely partners who would be interested in promoting injury and violence prevention, and some less likely partners, when I was listening to that discussion, if issues around, upstream issues are important, whether it's partnering with education groups or housing groups, various social awareness organizations, health equity focus groups. There are many groups whose central mission is not directly impacting injury and violence prevention, but that part of the work that they do is in support of injury and violence prevention. So I always like casting as wide a net as possible. And so this letter that we published a week ahead or 6 days ahead of National Injury Prevention Day, we put it out with a news release. We've circulated it pretty widely. Feel free to use this for any purposes that might that you think might help raise awareness of these issues. Now, the second thing around this is, there are threats. So while this is nonpartisan or bipartisan, there have been threats to different aspects of injury and violence prevention, including not just defunding those efforts, but looking at an agency like CDC and saying that, hey, the main purpose of this agency needs to be infectious disease. We need to put all these other programs somewhere else. Now, putting it somewhere else outside of the CDC is enough of a problem, but putting it somewhere else and defunding it is a whole nother thing. So I would be extra careful. I don't know if careful is a word, but in the coming months to really contact your state, your local, your federal policymakers. Tell them why the work that you do is important. Tell you why it needs, financing and support. And sad but true, but I counted back to how many administrative changes I've been through since I've been a public health professional, and it's 10. Ones that troubled us and ones that didn't trouble us. So to put a positive message out, I've often been surprised over the years when you think the threats are biggest that you make some really solid advances. So for those of you, who are somewhat concerned, over this past election, from a nonpartisan standpoint, you may be surprised. So it's like be equipped to make the arguments that are necessary to bring additional resources and attention to injury and violence prevention on the one hand. On the other hand, keep rather eye on any threats, including an effort last year to completely defund the injury center. I look at these. I look at leadership change as an opportunity to just do a better job of making our case, raising awareness, talking to the right people, and definitely identifying champions. I mean, it's all about having champions. Who's going to carry the water for our issues, and that has to be bipartisan moving forward. And as Dr. Arwady said, these are bipartisan, nonpartisan issues. Who shouldn't be concerned about suicide prevention, fighting the opioid epidemic, and promoting safe practices in transportation for kids, for adults. I'm excited that the support, definitely appears to be building, and I would just urge all of us to work together, be positive, and accomplish some good things in the coming years. So thanks, Delaney, for the opportunity to speak for a couple of minutes. Appreciate it.
Thank you, Richard, and thank you to everyone here today. This was the kickoff of National Injury Prevention Day, your day, our day, everyone's day to take action, to demonstrate to the world the need for injury prevention, to show up and show out and tell everyone what your biggest problems are in your communities, in your state, at the federal level, whatever it may be that you choose to address. I want to thank all of our NIPD partners, the American Academy of Pediatrics, the American Trauma Society, Be Smart, JPMA Cares, National Drowning Prevention Alliance, Safe Kids, Safe States, Saver, Trauma Center Association of America, and the Giffords Foundation for their support this year in helping us put this together and making this 5th annual National Injury Prevention Day a day to remember and a day to continue to grow and become stronger in the work that we do, and that is in saving lives and preventing unintentional, intentional injuries, all types of injuries for all ages, whether it's from 1 to 44 being the biggest issue, but everyone should be included and all injury mechanisms should be included. So thank you to everyone. And this concludes the National Injury Prevention Day kickoff event. Be well, do great things, and submit your events to the National Injury Prevention Day website. Join the Twitter chat, which is November 18th at 1 p.m. at the same time, EST. Use the hashtag #BeInjuryFree because that's the only one we can use. The other one does not work. I'm not going to mention it, but don't use anything else but hashtag #BeInjuryFree. Okay? And with that, I shall let you all go. In peace, be well. Thank you.